My gosh, we are on our final session with a amazing provider panel talking about telehealth providers who will be discussing accessible telehealth from really two perspectives. One, the perspective of individuals who are providing care for persons with disabilities via telehealth. And second, as people who have, some of whom may have disabilities themselves and what it's like as providers trying to seek care and making sure that when they're trying to provide care, that the solutions are accessible on the provider end as well, which we've talked a little bit about today, but I think we're going to explore that a bit more. So it's my great pleasure to introduce our session lead today, Dr. Rika Bajra, who is a clinical associate professor in primary care and population health at Stanford. She is the telehealth co-director for primary care and population health, and is the associate director for the core clerkship in family and community medicine at Stanford. She also served on the National Task Force for Telehealth for the American Academy of Family Physicians, and has been really a leading voice within Stanford for inclusivity, has done work with in medical education with objective structured clinical evaluations around telehealth, has mentored many a student. We've co-authored a couple papers together, and she's really a bright thought leader. She's very active in the American Telemedicine Association, and on top of being a wonderful clinician and educator, she's just a terrific mentor to all of her young people that she's helping bring up along with her. So it's again my pleasure to introduce her as session lead. And Dr. Bajra, take it away for our last session.
Thank you, Malathi, for that very kind introduction. My name is Rika Bajra. I am an Asian woman in her late 40s. I have shoulder-length brown hair, now peppered with some grays. And today I am wearing a blue shirt. I am wearing glasses with white frames, and I have a virtual office background behind me. I am thrilled to be here with my panelists. We went across the country to look for providers who are passionate and dedicated towards providing telehealth and really improving the care for everyone. And today's focus will be on how we improve care for persons with disabilities in telehealth. I'll broadly introduce everyone, and then I'd like everyone to meet each of our panelists, and they'll introduce themselves with visual cues. So I'll start with the broad introductions first. Dr. Alka Mathur is a Stanford-trained psychiatrist. She is currently serving as adjunct faculty for Stanford. She was the former medical director for the VA Palo Alto Healthcare System's telemental health program, where she managed telepsychiatry, teletherapy, teleaddiction, and tele-PTSD programs. Dr. Mathur, would you like to say hello?
Hi, everyone. I'm Alka Mathur. I'm a middle-aged South Asian female, late 30s, with dark eyes and black hair. I'm wearing a black-colored top, and my background is a top shot of the New York City skyline. I'm thrilled to be here. I have a strong interest in telehealth. I actually authored the telepsychiatry chapter for the APA residency handbook, and my strong interest lies in the expansion of virtual health applications to increase access to care for all patients.
Thank you. Next, we have Dr. Alicia Wong. She is a family physician working in the primary care safety net and a lead physician with Adaptive Primary Care, the primary care clinic serving patients with mobility impairments, including spinal cord injury. Dr. Wong is an experienced researcher. She has published many academic articles, including the provision of communication accommodations for persons with disabilities. Dr. Wong, would you like to say hello?
Hi, Dr. Wong. I use she, her pronouns, and I am a late 30s Asian woman with shoulder-length hair, wearing some red glasses and a white shirt and purple cardigan. I'm also will self-identify as a person with a disability. I was born with a physical disability, and that was kind of my initial interest that got me into disability advocacy and disability health equity.
Thank you. And we're very privileged to have today Commander Christy Clark. Commander Clark completed her pediatrics training at Duke University and joined CDC's Epidemic Intelligence Service. She is Senior Advisor on Data for Health Equity. She works in the CDC's Office of Public Health Data, Surveillance, and Technologies. She's worked on multiple public health emergencies across the world.
Greetings, everyone. It's my pleasure and my honor to be with you today. My pronouns are she and her. I'm a white woman with brown hair pulled back, wearing a white collared uniform shirt with dark shoulder boards. So pleased to be here.
Thank you. And then we have Dr. Evelyn Terrell. Dr. Terrell has a doctorate in occupational therapy, and she is a health system leader in pediatric care. She works as a director of global health and telehealth at Nicholas Children's Hospital. Dr. Terrell is a vice chair for the American Telemedicine Association Telerehabilitation Special Interest Group.
Hello, everyone. Such a pleasure to be here. My name is Evelyn Terrell. I am a white Hispanic woman, starting middle age. I have long or mid-length dark brown hair with some highlights. Behind me, there's a wall, a yellow wall with a frame painting with some blue purple hues. I am currently the executive director of strategy, just recently promoted at Nicholas Children's Health System in Miami, Florida. Also serve as adjunct professor for some of the local university programs. And as was said, I am also a trained occupational therapist over 24 years. So thank you and looking forward to the great discussion.
Wonderful. So I'm going to start with Dr. Mather. I know with your experience as being medical director during the time of change where the VA was implementing incredible changes in telehealth, this was probably a very exciting and also challenging time to be medical director. I'd love to hear experiences and what you see as the successes and challenges, in particular in serving our patients with disabilities.
Yes, absolutely. I'm happy to share. So I've actually been doing only telehealth since 2016. I can't remember the last time I saw a patient in person. And since that time, a lot has changed because of COVID, but I wanted to kind of go back to my experiences in 2016 when the veteran population in the VA, many of them had not been exposed to telepsychiatry or using virtual applications to deliver healthcare. And it was a really difficult transition for them because I actually had just started the role. These were patients in very rural clinics who were used to in-person doctors. And suddenly I show up and tell them, not only can you not see somebody in person and start over brand new with somebody else, but you have to see me by video. And it was extremely challenging. But, at the end of the day, many of them had no option. And what I wanted to do was really address their concerns. So whether it was a concern of technology, whether it was a concern of privacy, the ability for them to connect with me, that is something I've actually learned over the last 8 years. And I've tried to teach to my medical students and residents. There's a way that you build a rapport as a provider. You have to look directly at the camera. You want to center yourself. You want to present as a figure that patients can trust, that they look to you for advice. If you're kind of haphazard, looking everywhere and not making eye contact, I personally, as a patient, would feel a little less comfortable divulging my innermost secrets, especially when, for me, I was working with veterans who had severe trauma, severe PTSD, sharing intimate thoughts. And so it was a lot of kind of just getting them to buy into this technology. Let's try one session, see how you feel. Let's do the next one. What worked for this session? What didn't work for the next session? And over the years, I found that one of the things that was helpful in building this alliance is for some veterans over time, they found that not being physically in the same room as a provider was actually somewhat freeing in relaying some of their stories. And this I actually noticed not just with my PTSD or trauma veterans, but patients who struggle with anxiety disorders or depressive disorders that prevent them from being able to leave their house. But there's something somewhat freeing of not having to see somebody in person that allows you to really discuss, maybe uncomfortable topics, embarrassing medical concerns that you may have. And I found that to be very, very helpful and use that as one of the positives for telehealth. It also, for the veterans that I worked with and a lot of the patients that I have, cut down on the need for transportation. So the clinic that I was located at is, several hundred miles away from where these patients were located. So the cost of travel, that difficulty of travel, if you have a physical disability, the possible need for a third party for transportation, taking time away from jobs or childcare was really difficult. And it was great to be able to overcome that by using telehealth as an option. When I was in the VA, I was actually really impressed by their program because they have these Wi-Fi enabled tablets that we can send out to veterans who don't have access to technology or who don't have access to Wi-Fi. And we found it incredibly helpful because veterans could receive these tablets. There was a number that they had to call, toll-free number. And then there was a person on the receiving end of the line who was a technician who was really skilled at working through and walking through each step of how to set up these tablets, how to do a video visit with these patients of all varying types of disabilities. And it was incredible because for the most part, many of the veterans, when I started meeting with them, they actually at least had the basic understanding of how to use these tablets and these iPads. So I didn't have to spend too much time, getting them used to it. It was the idea of getting comfortable with the technology, but at least that initial hurdle was kind of overcome with regards to having technicians on hand. With regards to some of the challenges, there are privacy concerns. So for some of my veterans with disabilities, I could only see what was in the line of vision for the camera. So if there are other people listening or they live with multiple roommates, it was difficult to control that in certain instances. And we would try to do the best that we could with regards to maintaining privacy. The other huge limitation is a limited knowledge or limited access to technology, which, as I mentioned, the VA was great in that they were able to send out the iPads or tablets. We had a technology, line that they could call to get instructions. But there's still barriers to that. It was still difficult for many patients, and some patients ended up choosing to come into clinic to be seen. And the other option that they had where there were smaller satellite clinics where they could do a video visit with me, but instead of having to travel 4 or 5 hours, they could just travel maybe 20 or 30 minutes to a clinic that was closer to them.
I think that's really amazing what the VA has done. I recently read this article about telehealth use by persons with disabilities during the COVID-19 pandemic. And this article demonstrated that persons with disabilities who had VA insurance were 1.7 times more likely to use telehealth than any other insurance, really speaking to the programs the VA has put in place to make this accessible. And as you mentioned, making a personal connection and making it feel safe for patients. And so I think that, we have a lot to learn from that. Throughout this conference, we heard from various patients about what are some of the challenges they've experienced in telehealth and how these can be different depending on the disabilities experienced. I'd like to now turn to Dr. Wong, with regards to your experience in working with patients with mobility impairments at your clinic and what your thoughts are in terms of how we can continue to push the boundaries of how we advance equity and accessibility for patients.
Yeah, I think what I have to say is kind of echoing what's been said already, but I think it's certainly the main thing that telehealth provides that we can't provide in person necessarily is the access. I live in Colorado, and so rural access is especially difficult for subspecialty care, especially, but also primary care, transportation difficulties. And so that's kind of the main potential and benefit of telehealth. Some challenges that I've seen in my practice, especially working in a safety net hospital organization and a federally qualified health center, is that we have a lot of people who don't have stable internet, don't have a smartphone or a phone personally for themselves. They don't necessarily have a private place to talk, especially for people who are not English speaking or have limited English proficiency. It's really difficult sometimes to navigate the portal that we use, and our telehealth is embedded in our electronic health record. And so they have to be able to navigate there and navigate the application to do the video visit. It's also been somewhat difficult for people with communication disabilities. A lot of my patients who have either hearing difficulties or processing difficulties, for example, they would prefer often to come in person. Some of it is really getting out what we need to have in telehealth. So we need to have, closed captioning options, the ability to share graphics and images, instructions, point out things, enlarging images for people. And then the same is true as well for also some caregivers who also have disabilities or limited English proficiency. So that has come up as well in my practice.
Thank you. I think that we heard from some of our patients earlier today about the importance of closed captioning and also direct texting or direct text capacity to be able to communicate, sometimes even in a way that they want to communicate directly without the use of a translator. So I thought that was really valuable and very important for us to hear as providers. I wanted to thank you both for your incredible work in advocacy. It's clear that while telehealth provides a patient-centered option, we still have a lot of work to go with regards to providing technology support that's patient-friendly, as well as integration of ASL and other languages, the availability of things like closed captioning. And I remember in our prior conversation, Dr. Wong, you've also talked about how your work involved including patient accommodations in the EMR, the electronic medical record. And I wonder if you could speak to that a little bit.
Yeah, absolutely. I think one of the main things that we need to do collectively as a health profession is to track disability status and accommodations in the medical record. We really don't, at least for the most medical record systems that are out there, there's not a great way to do that. So if we don't know which patients need accommodations and we don't know what accommodations they need, then we can't provide equitable care. And so a huge component of that is going to be regularly tracking and collecting disability status, similar to how we collect other demographics. And then also updating the accommodations that are needed and having that get flagged prior to appointments. And we need it to be available in every single clinical setting for every person who comes into contact with that patient, whether that's patient registration or the pharmacy, and all of the other environments that they're interacting with. I think that's really important. And also similarly, along with some people who may have caregivers or guardians, we also need to track the accommodations that perhaps their caregivers or guardians or care partners need as well for those visits. And so that's going to be a critical thing that we need to move forward and as part will be great for providing population health data long-term as well and enable us to follow clinical outcomes.
And I think that's a nice transition point to look at how we can improve beyond the patient and provider level, but at the national and global level. So I'll bring in Commander Clark here. She's been doing really important work in looking at data, essentially during the COVID-19 pandemic. Her team looked at populations that were disproportionately affected, exploring data that might be missing to allow public health authorities to identify and address health disparities in real time. Commander Clark, thank you for being here. Could you tell us the main findings of your team's work and why it's so important to advance the care of persons with disabilities?
Absolutely. It is my pleasure to be here with you. As a reminder, I'm the white female panelist in a white uniform shirt. As Dr. Bajra mentioned, for a year and a half during the COVID-19 response, I led a team that worked really tirelessly. These guys were amazing to identify and address the impact of the pandemic among many groups that have limited visibility into the disparities that they face. So I had a unit of subject matter experts on people with disabilities, also older adults, people experiencing homelessness, experiencing incarceration, and those with substance use disorders. So there were substantial limitations to the available data for these populations. And that made our work even more difficult. I learned so much from this team and from that work, particularly from the folks in our Division of Human Development and Disability. They taught me a lot. In the area of data, which I'll focus on today, the number one thing that I learned was this: populations that are overlooked in the design of data systems are more likely to be underserved in public health practice. So data that quantify impact go a long way to shape priorities, to shape what actions are taken. And of course, we all want there to be evidence-based actions and investments, right? Makes a lot of sense. But we need to ask ourselves, who maybe is not included in that evidence base? And if they're included, who may not be adequately identified in those data? So at that time, we worked with the data that we had in the best way that we could, given what was available. The limitations with regards to disability data in that context were threefold, primarily. First, disability status was on the case report form, but was not a prioritized variable. In the face of so many cases, it was very incomplete and difficult to work with. So we shifted to looking at de-identified data from electronic health record databases, or EHRs. So second challenge there, that's not standard to screen for disability. So we had to caveat that with there are biases to what exists in those databases. So a disability would be more likely to be recorded if it's visually apparent, requires, obvious accommodations in the care setting. And I can put the paper in the chat, certainly some other limitations in there. At that time, third limitation was that at that time, there was not a data standard for disability. So I'm a pediatrician, not an informatician. I know a lot of you guys are providers as well. So I'll try to translate the importance of this. So imagine your electronic health record like a train, and it has a car for each data element within it. So on health information exchanges, say you're going to another hospital system, right? That train can go to a depot, it can switch tracks. Now, with the data we're working with, if it's de-identified, you can actually take some of those cars off the train, like the name, but the car for the age or a medication remains. No matter where those cars go or what train they're on, they are understood as, for example, 40 years old or lisinopril. But there was no standard or train car in this analogy for disability status. So all of this work over that time, experiencing those limitations, it really grew in me a determination to work on the systemic issues underlying this so that next time others have better tools to help. So in 2022, CDC proposed a data standard for disability status, thanks to the disability experts I worked with and supported probably by some of you, key partners and advocates in the disability community. And that's through something called USCDI, which sets data standards. And as of January 1st, 2026, disability status will need to be a data standard on health IT products like electronic health records that we all use in order for them to be certified by the Office of the National Coordinator for Health IT. So we're excited it was accepted and that it's on the calendar. We're working toward other equity-related standard. So a widely implemented standard is really, like I said, a requirement to make such a key demographic able to really be included in the future of, health data and public health. Other areas we've been working on are incorporating more community engagement into data for equity work, as well as working on prioritization of improved data on social determinants of health. So I'll just say one additional thing, which is that we set concrete 2-year milestones in my office, and our 2025 milestone is that half of the centers that comprise CDC will report new social determinants of health data elements in their visualizations and reports. So excited for the future, and it is a long process, and appreciate partnership from all of our partner organizations and advocates as we continue this really important systems-based work.
Thank you, Commander Clark. Your work of bringing visibilities to these disparities is so important. I think about what we were talking about earlier in the conference. There were several components of the conference where the topic of if you can't measure it, you can't improve it came up. And this is another theme that we're bringing up here in our session. I wanted to get your thoughts in terms of how can organizations use the data you're collecting to best serve persons with disabilities? What kind of actions would you want communities, individuals, advocates to take?
Yeah, well, first we're working toward making disability status also part of the minimum data necessary, for response, for data collection to really make sure it's recognized as the important demographic that it is. And in terms of data, a lot of the data we used are data that are in the healthcare system, healthcare databases. So I think the number one thing is to all work together, especially as these standards are going to be implemented, to help the data within those systems be more complete and make sure they're implemented. So I would say, things like asking your health IT or electronic health record provider when and how they're going to be implementing the data standard for disability in their systems. Like, will it be in the demographic section up front? Like, how prominently will that be incorporated? I think that'll be important. And in terms of feasibility, there's some great research out there. If organizations are, have concerns about regularly, making sure to screen among folks to make sure that they do understand everyone's identity. Dr. Megan Morris out of University of Colorado has done some interesting studies on that. But yeah, working toward better data and better data collection with not only health IT vendors, but also within organizations to prioritize this as a really vital data element.
And I'm going to loop in Dr. Terrell here. You have experience in both frontline, on-the-ground interventions, as well as health systems interventions. Can you share a bit about your team's telehealth experience? And I'd like to get your thoughts on how organizations can use this data and how we can push the boundaries to advocate for better telehealth services.
Thank you. My pleasure. Our organization, Nicholas Children's Health System, started a telehealth program in 2013. So we had a program live 7 years in. When the pandemic hit, we had a telehealth program that was operational, a platform, and a good amount of providers that had delivered, not providers, but specialties that have provided telehealth, but very few and far between utilization, right? There was a lack of the payer landscape was not supportive, and all the barriers that we understand. I started my interest in telehealth in my doctoral studies, and I chose autism as my area for my capstone project. There was an autism spectrum disorder service or program, and it was targeting the rural population, which is the Florida Keys. It's about a 3.5-4 hour drive from the middle of Miami to get to the end to Key West, and all of that area is very underserved. We had 71 patients that had been identified as needing services as part of the Early Steps Intervention Program, state program, and only 4 providers in that 3.5 hour drive. And so that was my first interest, was that serving that population. We piloted the program. We partnered with the Early Steps program, as well as infant toddler developmental specialists that were going into the homes. And we were able to connect in a interprofessional collaborative model, consultative model, connecting those professionals that were going into the homes to our therapists back at our main campus, occupational therapists, speech language pathologists, and physical therapists. And it was very successful. It helped having that collaborative approach, because patients and families were not really, it wasn't mainstream. Telehealth was not as embraced back then. So that was a very appropriate approach, and it was very successful. We were successful at serving populations. Fast forward to the pandemic, we were still serving this population, but now the model changed, and it was more of a direct patient model, right? Direct to consumer. And again, being able to serve the families in a different model, but continuing to have provide that continuity of care for them. And of course, expanding services. We went from prior to pandemic was very much focused on direct-to-consumer model. We were serving mostly patients in the school system. We had a very successful program in the school system. Again, more of that B2B model, right? To an organization, to a community organization, entity. And then again, moving to a more direct in 25 specialties. So now we provide services in 25 pediatric specialties. Some of our most common are GI, gastroenterology, neurology, genetics, endocrinology as well. And again, we have different models. So the models are, again, not just that direct-to-consumer model, but we also partner with adult health systems that are lacking the pediatric expertise. So that includes outpatient services as well as inpatient care. We provide inpatient services to 10 hospital systems, 4 health systems, but 10 hospitals in our South Florida area. And what we found in all of those models, patients embrace telehealth and providers alike. It's been our satisfaction scores have been in high 80th percentile to 90th percentile. When we compare in-person services to telehealth, the in-person, the telehealth services score higher for every question asked, with the exception of overall satisfaction, which remains about the same if we compare the in-person to telehealth. The other metrics that we measure is also travel, and the data, going back to the data, we measure a lot of these different metrics and KPIs, from satisfaction to the travel savings for the patients and the families, to how successful are we at getting patients in within 7 days, which is one of our organizational metrics that we measure, how often we are able to see those patients within that 7-day access. And along the way from the journey of telehealth, pre-pandemic, post-pandemic, we really looked at that data to see how are we doing. Things like what was mentioned in one of the sessions is the wait time for the family seems like an eternity if they're staring at a screen. So we track the data to see how long does it take a provider to join that video visit. We tell the families via SMS text and some of that communication pre-visit that they're going to see a provider within 15 minutes, but even 5 minutes is too long for them. So we have processes in place now so that we can have an assistant or an MA role check in with the patient if the provider is going to join a little bit later, is running behind. We also have virtual interpreters and a process, like Dr. Wong mentioned, the importance of capturing that data at the point of registration, such as what are their language needs. Do they need a Spanish interpreter or a Haitian Creole interpreter? Do they need an ASL interpreter as well? And what is their preference, right? Because we're always giving the family a preference. The hybrid approach is we're able to see you. This provider is able to see you via telehealth, and we can provide an interpreter. And again, it's their choice to be able to, what is their preference. So those have been some of our experiences and our journey along the way. And I'm happy to dive into any of those areas.
Thank you so much. I think that what I'll do is I'll turn it back over to Dr. Wong and Dr. Mather to see if you have any thoughts in terms of how individual providers, we can take action, or we can make ourselves more useful in this journey towards improving telehealth for persons with disabilities. For one, I'm going to take Commander Clark's advice, and I will be asking when and how our institution will be implementing the data standards for disabilities. But I'd love to hear your thoughts. I know that Dr. Mather, you do a lot of teaching, and I can see a lot of applications in education. And Dr. Wong, I believe you are part of a collaborative and do a lot of advocacy work. So I'd love to hear your thoughts.
I'll go first. This is Alka Mathur again. I'm a South Asian female in my late 30s wearing a black shirt and a backdrop of the New York City skyline. So I am a big believer in education of incoming providers, medical students, residents, trainees, education of current providers and people who have been practicing for 20 or 30 years. I think one of the things that we lose over time with telehealth, or that I've seen so far, is that it becomes so familiar. It feels almost like a FaceTime. We all know how to video chat, but we forget the nuances, especially in working with patients with disabilities. So creating a standardized protocol, whether it's with your institution or your private practice, to address a variety of disabilities, whether it's physical, emotional, mental health related disabilities, and continuing to train our young providers as well as our current providers how to address those needs while we are implementing telehealth to a broader scale, as each year passes. The other thing I really think is very important is advocating for various systems to help provide technology for patients, particularly those with disabilities. It's still a huge impediment. We tend to think, oh, everyone has a cell phone or some kind of access to a laptop or an iPad, when that's truly not the case. I think as the government, as healthcare systems, it's our prerogative to really make sure that everyone has access and everyone is kind of placed on equal footing with regards to being able to receive quality healthcare.
Dr. Wang, did you want to pitch in your thoughts?
Or so in answering about the Disability Equity Collaborative, so that was founded by Dr. Megan Morris, and I'm one of the members of that as well. And so I would definitely, kind of going off of what Commodore Clark mentioned, we have a extensive implementation guide on documenting disability status that I would definitely look at and use as a guide as you're trying to implement that at your own institution. It definitely runs you through the instruments and the common questions and kind of the multiple various workflows that you can think about in actually collecting disability status. And also just joining our newsletter to be aware of presentations and groups to join as well. In regards to providers specifically, I completely agree that provider education is going to be one of the biggest things. We don't learn in medical school or medical training how to care for people with disabilities. I think we can all count on one hand, if that, the number of experiences, and really it was like an experience or an exposure, but not anything longitudinal, not necessarily anything meaningful. And a lot of the difficulty in accessing good care is finding providers that feel comfortable and feel like they can actually provide as high quality care to people with disabilities. And I said that for myself, I have a lot of difficulty sometimes finding providers, even as a physician, who really I feel comfortable with going to, and I don't feel that they're having some internal bias, just because a lot of the times uncertainty will bring out your internal biases. And then also just the physical environment, really pushing your home institution to make your clinic environments, your hospital environments, all the environments that patients interact with accessible. One single bathroom or one single handicap opening button for the entire building is not appropriate. Most patients that we see have difficulty getting on the majority of the exam tables that we see, getting weighed regularly, and that's just looking at physical disabilities alone and more taking into account multiple disabilities. Most people have multiple different types of disabilities, and so it's kind of trying to think about how to holistically create an inclusive environment. The second thing, or another thing to think about too, is really just to advocate at a policy and legislation level for kind of good, adequate reimbursement for your time to really give adequate care, and also for telehealth. So I know a lot of my patients, for example, we do a lot of telephone visits, and I think during the COVID pandemic, those were as adequately reimbursed, and not as much as video currently. And so kind of really advocating for the various modes of communication and the way that care can be delivered, but also ensuring that providers have enough time. I think that's another limitation, and where people feel hesitant to necessarily welcome people with disabilities and care for them adequately is really we have limited time, and then we even have less time if we're need to use an interpreter or have difficulty with access issues like getting onto the exam table, etc. So we really need to have reimbursement that is reflective of the care that we're giving.
Such important points. Thank you so much. I think we might be near our 10-minute mark. I'm going to read some of the questions here so that we can move on to the Q&A section. One question is for Commander Clark. It says, the participant asks, are there efforts to collect improved data concerning disabilities of healthcare providers themselves, for example, by professional associations for physicians, registered dietitians, nurses, etc.? My professional association thinks it's illegal to ask members to report this.
Well, I'm going to start off by saying I'm a pediatrician, not a lawyer. For sure. So I don't want to override any counsel. We don't, the CDC track disability status of providers. I think that's an interesting idea, and I'll have to give that some additional thought. But I think that, it is an important point to have, awareness of the diversity of our community as healthcare providers, and how we need to make all of our spaces accessible to everyone. I think that there can be limited awareness of that. So yeah, thank you for bringing that up. And I would be curious to learn more.
And then a question for Dr. Mathur. What impacts have telemedicine had on veterans' disabilities outcome?
There's numerous studies showing great improvements in PTSD tracking scores and anxiety scores, depression. So there's a lot of work going in, a lot of research going in the VA hospital system, as well as elsewhere too, about the benefits and improvement. I'm speaking particularly for mental health disabilities. I'm unaware of others, but in the mental health space, there's significant data showing drastic improvements equal to, and in some cases, potentially even exceeding the improvements that are demonstrated by in-person visits. As I mentioned before, some of that may be related to the idea that for mental health care, certain times patients may feel more able to share their innermost thoughts when the provider's not sitting in the room, and that may be part of it too, for the studies where there was an improvement over in-person.
Thank you so much. I wonder if Dr. Terrell, you could give your thoughts in terms of pediatrics. It would be, we could sort of translate that question into pediatrics in terms of what kind of outcomes you've seen in pediatric care.
So we have done some studies and quality improvement projects, and I'll mention just a few that come to mind. Is one of the programs that we launched was our palliative care services for families and terminally ill children. And we do not provide home health services, and we found that those patients were not receiving care, right? But sometimes it could have been delayed, or there was really a lacking opportunity to collaborate with those home health providers and hospice providers that were in the home. So we started the program. We have been able to see patients within a few days of discharge, within 7 days, more than 80% of the time. We've seen very great satisfaction and ability to reduce readmissions for not just those types of patients in palliative care, but also our NICU patients, neonatal intensive care families that we're also following post-discharge. Reduction in readmissions, reduction in ER utilization, emergency room utilization for those families. Those are two programs that we've studied a little bit more extensively. And then other benefits such as I have mentioned, the satisfaction, the access to care, and other types of outcomes. And at the end of the day, they do translate to positive outcomes that families that are able to receive care that otherwise would not have received.
Thank you. I mean, those are really important, and indeed, optimistic that we can use telehealth in this way and continue to use this as we move forward. We'll use the last few minutes for just closing thoughts or reflections. I will have each of you maybe speak briefly in terms of what are your thoughts in terms of maybe next steps or just reflections from today's session. I'll have Dr. Wong go first.
So I think kind of just reiterating what I said before, I think this has been a great discussion. I mean, really improving care for disabilities can be uh, um, really any aspect of our work. I think education wise, clinician wise, system issues, policy issues, really kind of choose an avenue that you feel really passionate about and kind of go into that and be a good advocate locally, but also just be willing to engage in the work.
Vander Clark.
Yeah, I just wanted to say thank you for welcoming me into this space. I've learned a lot today, and going forward, just yeah, as terms of a call to action, encourage folks to look into how disability can be better recorded in the spaces where you work.
And then Dr. Mathur and Dr. Terrell, please.
Great. Again, this is Ulka Mather, South Asian female wearing a black shirt and long black hair. I think as I belabored the point of education for our new providers, increasing access for patients in order to receive technology or other resources that are needed to get the best care. I think on a separate note, I'm excited for what the future is going to bring. I think telehealth was one step, but there's going to be a huge surge in applications that will increase access for multiple different people, especially those with disabilities. Wearable devices, I think the sky's the limit with regards to what are the things that are possible in the future to enable broader access to care, and not only just broader access to care, but broader access to quality care.
And I'd like to echo what was said. It's very inspiring. It was a great day of learning, and I've gained so much. And one of the things that I came out with is that there's always opportunity for better. We've come a long way. There's been a great journey. Myself, having been in the telehealth space for 11 years, and it's been a journey of improvement along the way. And there's always room for more. I just today I've learned how can we better serve patients and individuals with special needs, and how to could do it together. Collaborative. There's collaboration that is involved, and we could do it together with that collaboration. So thank you so much for this opportunity.
Thank you. And I'll go ahead and close our panel and turn it over to Dr. Srinivasa.
So I can't thank our panelists enough for such a rousing and stimulating discussion. And Dr. Batra, I'm going to ask you the same question that you asked the panel. So what is your final thought and takeaway from this conversation that you facilitated?
Oh, thank you. I wasn't expecting that, so I'm a little bit taken off the spot, but I mean, but I would say that, yeah, I also agree. It's been such an inspiring day. The talks throughout the morning and afternoon. I mean, I was like pretty much glued to my screen. Usually, that's not the case for me for Zoom conferences. So thank you so much for this wonderful day. I think that it has been a really rich discussion. I thank you for the opportunity to meet all these lovely providers. I've had an opportunity to meet and talk with them, some in person and all of them individually. And it's just been such a pleasure. Thank you so much.
Well, we're so privileged to have all of you here, and I hope that as we move forward, we'll all continue to collaborate on this issue. First on the white paper, and as you know, telehealth is an important instance of digital health, but there's many more things to talk about in regards to digital health and disabilities and other vulnerable populations. So we're excited to have this be part of an ongoing conversation and have this be the first of many. I wanted to share a few closing remarks, and including thanks for so many of our participants for sharing their ideas and thoughts with us. We'll also be thanking the conference organizers. There's a lot of behind the scenes people we need to say thank you to. So if you'll bear with me for a few minutes, I'd like to first thank all of the participants today, this entire community of over 1,000 people who joined our conversation. Thank you for being invested in this and caring for your friends and family and forming the why of why we're actually here today. So it's your interest and your consideration and your great questions that have made this even more special, along with the expertise and thoughts of our panelists. I hope that we've made the case through the course of this day that the original premise that we started off with this morning, we've proven to you, which is that for many persons with disability, telehealth has become a public good in improving access to healthcare. But as we've demonstrated through each of these sessions, although we've come a long way, we have a much further way to go to making sure that we can really ensure high quality care for all persons with disabilities and all people everywhere. We had dedicated the conference to Andreas Gallegos, and I wanted to share a quote from him. The predicate of our ability as persons with disabilities to live, to learn, and to earn is to attain and maintain good health. And it's for these reasons that our abiding focus will be on healthcare and addressing implicit and explicit bias against persons with disabilities in healthcare. And I think his idea of having our house on fire is true. We saw through the pandemic exactly what happened to persons with disability, with marginalization and increased deaths. And we see the tools at our disposal now to improve care in a variety of ways, both for in-person care, but certainly for telehealth, which can make care more accessible and easier and hopefully more affordable for many people. I stole this slide just now from Susanna for her presentation when she said that, we need to think about how do we make healthcare inclusive to drive equitable outcomes, and thinking about person-centered care, which many people brought up today, with a person, provider, technology, and health system. So thank you, Susanna, for letting me borrow your slide. And I wanted to go over, just since we're recapping the day, a few highlights from each of our speakers, because we really did have quite the journey today. We started off with Anne McIntosh from the National Council on Disabilities, sharing their framework to end health disparities with 5 key components. And they've made significant progress on 2 of them, and a third on improving data capturing, and still have the ways to go, I think, in their roadmap, but they have a roadmap for the future. Kyle Zebley from the American Telemedicine Association shared that 2024 is a Super Bowl of telehealth, with the reauthorization of telehealth legislation, which will require all of our collective effort to advocate for all persons to continue to have access. And hopefully, as many people have mentioned today, also that we can have a telephone equivalent to telehealth and really customized to the needs of the patient, rather than a modality that we think about what the patient needs and then create systems to be able to support them. ATA has a renewed focus on vulnerable populations, including persons with disabilities, and they'll be spending some time with us on that. Katie Rigat from the AAMC had talked about academic partnerships, and they have begun doing significant work in telehealth and disabilities. They have an anti-ableist medical education platform that they've been developing, and they have called on you to watch Learning Series 4A and 4B, and I believe it's on vision and hearing disabilities. And so, Katie, you'll forgive me if I got that a little bit wrong, but please take a look at those videos and take a look at their learning series. They're very good. Purna had shared with us the perspective of persons who are deaf, deafblind, and hard of hearing, not dear, that's a typo, and some practical solutions that we can implement from having text captions and Braille to really focusing on provider and patient education to be able to engage these vulnerable populations, and especially people with multiple disabilities, more effectively. The vision panel on blindness and low vision had talked about everything from capturing low vision outcomes in the EHR and the fact that if it's not measured, we really won't be able to make a change. And we need to focus on usability, not just accessibility, and thinking about all the things that people face, from login and registration to the interfaces that we have, and making things sufficiently easy. And we need to have better visual enhancement techniques on telehealth, which our technologists can help us with, along with standards for interpreter descriptions and better training for providers. Dr. Skelton talked about issues with mobility impairment and a mobility disability, and some of the from a really an ethical standpoint, and took us through a journey of the ethics of telehealth, and then bringing us to the practicalities of what is faced by persons with mobility, along with additional things that we need to think about as we're building out systems, and even thinking about national programs where we can share resources, which would actually require a re-architecting of medical licensing if it was done in the VA system manner, where people can practice not just in one state, but in many, especially for those conditions that are more rare or required specialized training and access. Our technology panel had talked about how we should consider the greater good in decision making. For instance, thinking about when we should focus on accessibility versus security, and thinking about from a cost of development standpoint and a cost of the consumer standpoint, what type of global regulatory requirements should be in place, and how we can lower the bar to development, and improving connectivity to make things as seamless as possible between all of the different elements within health systems and technologies and third-party systems that all need to work together to be able to provide a good experience for the patient, and simultaneously thinking about new ways of engaging communication and enabling data technologies. Our IDD panel and autism panel had talked about the fact that there's not that much data on telehealth for adults versus that for IDD and autism for kids. And that telehealth in some ways may relieve some of the sensory overload, but it's not optimized for the IDD autism population. And there can be real challenges with personal connection and communication, especially if the adult with autism or IDD is working with a new provider. And the range of neurodiversity challenges us to customize all of our solutions. The cognitive disability and dementia panel had defined for us the many different types of cognitive disability that we may face, and how we can use some of the elements of telehealth to be able to better meet the needs of persons with dementia, from attention and eye contact and privacy to things having to do with physical and intellectual and emotional safety. Our provider panel talked about quite a few things, from the need to track disability and accommodations in the EMR, and the fact that the CDC has created a new US CDI systematic data standard in 2022, which is accepted for EMR certification by 2026, which will be a major advance in terms of the reporting standards that we have to be able to understand what type of accommodations people need and what standards we need to have to be able to meet their needs better. We have so much work to do in training our providers on how to best take care of persons with disability, and preparing our patients also in a way that reduces their learning curve and makes it easier for them to onboard. We need to be concerned about challenges with provider time. We have to sometimes slow down to be able to make sure that we are not leaving people behind, to check for understanding, and to begin to think about how, especially we work with non-English language proficiency patient, share graphics and large images, do some of the technologic things, but also think about who within our workforce has disabilities within the healthcare workforce, and what type of accommodations they need so that they can use these new techniques and technologies efficiently and really enjoyably, so they can connect better with their patients. So I've been asked several times through this conference, online and offline, sort of what our next steps are. And I hope that we've proved our premise that we need to do work in this area, and it's in many ways a moral imperative. In the next 6 months, we're hoping to develop a white paper building on this conference for best practices for disability and telehealth, bringing together all of these different groups who've spoken today. We would invite you to become part of this conversation. We have invited you several times to share your stories with us, and we have a survey in the chat that you can complete and send us your stories and ideas that way as well. We are going to work very diligently with the American Telemedicine Association and the AAMC and our other partners here today. Hopefully the CDC as well, if Commander Christie is open to that. And once we have our draft white paper, we'll post it on our website and other websites for community comment. And once we receive community comment, we'll go back and refine our recommendations. And then once it's ready, we'll take the National Council on Disability up on their very generous offer to present our ideas to them to one of their health groups sometime in the next 6 to 8 months. So I wanted to, so that's where we're going. We'll probably do a couple other conferences on additional topics related to telehealth and the digital health ecosystem. But I wanted to spend a few minutes thanking all of the people who've made this conference possible. And it's been quite a few people. The first person to thank is Devorah Kathari, who's our extraordinary event planner in chief. She's worked tirelessly for the past 8 months to be able to make this happen. We've met multiple times a week, and she has shepherded this project from idea to the conference that you see today. It wouldn't have been possible without her. We'd like to thank all of the people who are involved in accessibility, design, and administration, including Amy Thomas, Lester Andrew, Sheila Sanchez, and Catherine Beneteau. We'd like to thank our creative director for the COVID journey, who did a lot of the photography and videography. We didn't show you a lot of the videos, but Asa is a master photographer. And if you have a chance, please check out his website, asamathat.com. Asa, that's a plug for you. We'd like to thank our technology and social media team. They have been working for, gosh, months now, and all of the speakers have done multiple test runs with them to make sure that the technology and the work with the ASL translators and the closed captioning has all been seamless. And Louis is our fearless leader. And he's been supported ably in working with Eric Lee, Maya Matheny, and Nicole Turk. So they're on this call. I hope I haven't missed anybody here. And we also want to thank, in addition to some of the core planning committee, a couple other people that we haven't recognized who we really need to. Leah Rosengass, who is Stanford's lead for digital health at Stanford and has been doing so much work for in this area and had brought digital health along with Dr. Sharp to Stanford in a very organized way. Dachin Campbell in OBGYN, Kalpana Balaram, who is currently in narrative medicine at Columbia and was one of our research associates for this conference and for the COVID journey. Similarly, Lily Barr, who is a research associate now at the NIH and is a research associate for the COVID journey and has been doing a lot of the question answering for the Q&A on Slido for the conference and was helping us with conference planning. And we have two amazing writers, Erin Jarrell, who is a family physician and the speaker liaison for DM3P, and is helping us write the white paper, as is Maya Ramey, who is a medical student at Texas A&M. We'd like to also thank the board of directors for SMATI, who are all listed here. There's quite a few people, and they have provided the infrastructure and support and backbone for this program. And of course, we would also like to thank our sponsors, without whom today would not have been possible. And this includes the Stanford Medicine Dean's Office for Human Resources for Equity, Diversity, Equity, and Inclusion, the Department of Radiology, the Department of Medicine, of course, the American Telemedicine Association. We love you guys. Thank you. And all of the funders and groups at Stanford who have been so terrific and have been so supportive of us with the McCoy Family Center. Oh, that kind of went ahead. The McCoy Family Center for Ethics and Society, the Office of Faculty Development, Diversity Engagement, the Outside Professional Activities Certification System, OPACS, the Office of Research, Patient Care Services, Health Equity, and Diversity Inclusion, Equity and Inclusion Research Grant Program, and Medicinal Chemistry Knowledge Center, Seraph and Ken H. So again, for those of you who are planning on claiming CME, we would encourage you to do so. The CME attendance link has been placed in chat several times. I hope that you fill that out. Once you've done that, please also scan a QR code, this QR code, and you can claim your CME. We'll be sending out a email with a link both to CME as well as a link for people to share their stories with us as a follow-up to this conference. And with that, we'd invite you to stay in the loop. SMATI has many conferences, and this is one amongst them. We invite you to follow us on social media and also visit our website. So once again, thank you, and we look forward to continuing this conversation. And thank you also, of course, to my wonderful co-chair, Dr. Polos, who had to step away. But we'll all be in conversation, hopefully, for many years to come.